I'm not sure if that slide it constitutes a problem in terms of bias, but we'll put up with it. Hey, so what we're going to do is start with the discussion point. I would encourage the audience to try and use texting or Twitter if you have any questions or thoughts regarding this. I'd like to thank the group for an excellent presentation. And so what Mike and Peter and I thought was to facilitate the discussion, what we'd do is put out a framework to get started and ask and use this as a point to discuss SILS versus LAP, really versus open. And the scenario that was put forward was for colon surgery today in 2012, is it mandatory for a surgeon to discuss with the patient that that there's an option for open surgery, there's an option for laparoscopic surgery, and/or there's an option for SILS surgery? And if so, how do you handle that in your practice? So why don't we get started with you, Harry?
Good. Well, can you hear me? I actually do discuss all three options with the patient, but I don't do it as, an option, in terms of pick one. I basically state that, the patients are going to have better outcomes, shorter recovery, et cetera, doing it minimally invasive, and that if we have to alternate to an open approach, that might be necessary. In terms of differentiating between laparoscopic and single port, I think you're still doing it laparoscopically. I think it's important to state that single port is a change in the way you're placing your ports, and then informing the patient that they may end up with additional ports as well. I do, at least when I first started, I told the patients how many cases I had done, and if they felt uncomfortable, then we wouldn't offer it to them. But anyway, I think it's important to disclose.
How about you, Dan?
I still consent patients for all. I talk to them about SILS, about regular laparoscopy, but start the discussion with how the surgery is done most of the time across the U.S., which is an open operation. I also mention conversion rates and everything else, just to include the possibility of a bigger incision if needed.
Tonya?
Pretty similar. I talk about both lap and open, and if they're a candidate for a single incision, I'll include that in the discussion as well.
Actually, I don't include that in the discussion. I decide what I think is the best single incision, laparoscopic or open for the patient, and then I explain the operation to them. And I view single incision as it's just an approach, it's a type of laparoscopic approach, not a different technique. It just ends up providing, I think, unnecessary information. I don't think it's experimental. I think it's judgment. It's a judgment call on if we do it, we end up inserting extra ports. It's laparoscopic regardless. So for me, it's just laparoscopic or open in the discussion.
And Tonya, maybe you could get a start on this. What are your thoughts? I mean, this is what you all discuss with your patients because you're very comfortable. How about from a leadership or position standpoint? Should it be mandatory that general surgeons across the country discuss with patients that there is a minimally invasive option for colon surgery as opposed to just an open option, much in the way, I guess in the late 80s and early 90s, there was the big discussion as the trend went from modified radical mastectomies to lumpectomy and axillary dissection. It was actually mandated legally that that be discussed with patients. What are your thoughts in terms of how that should be handled, especially in light of the fact that only 1 in 5 cases in the U.S. seem to be done this way?
That's a tough one. I think there's some data that's going to be presented at this meeting showing that the uptake is actually closer to about 30% now. I think it puts people in the position of potentially having them try to do something that they can't do if you're saying that offering them something laparoscopically is mandatory. I think if there were an improvement in oncologic outcomes, that makes it a very different matter. Then you could say that it's mandatory that you have that discussion about a laparoscopic approach. But when your long-term oncologic outcomes are essentially identical, I think it's very difficult to say that laparoscopy should be mandatory.
Not necessarily mandatory, but mandatory in terms of offered as an option. And just to follow the breast cancer discussion further, it was never said that that had to be done, but it just needed to be, the patient needed to be made aware of that as a possibility.
Again, a midline incision compared with your standard laparoscopic extraction incision is not the same kind of disfiguring operation as a mastectomy is to a segmentectomy. I think it's a very different analogy.
And Harry, what are your thoughts on the matter?
Well, I mean, from a practical perspective, I mean, the majority of colectomy cases are done out in the community, and whether or not there are resources or skills available to provide that resource is somewhat questionable. You know, if every general surgeon that was out there, you know, offered a laparoscopic colectomy to patients and they took it, then a lot of patients would be referred into tertiary care centers or other areas, which might be a problem in terms of access. So I think, you know, the answer here is really going to be to educate and train people rather than mandate it.
I'd like to expand on the topic, not just malignant disease, but benign disease. We've got growing data showing that J-pouch patients do better at 1 in 5 years if it's done laparoscopically. We also know that bowel obstruction rates postoperatively are tremendously less. I think there should be an obligation there for all clinicians to discuss that with patients, that a less invasive way is going to afford them a lower risk of bowel obstruction. If we're doing pelvic work, possibly improved fertility rates in young women, as well as wound infection issues, lap versus open. So I'd argue that that should be discussed.
No one's tweeting or texting in, so I'll continue with the...
Can I ask a question? What do you think? I mean, just...
What do I think? I mean, I think that... I think clearly the point that Tonya and you have made is that it's not as dramatic as what I've used as the example of mastectomy versus lumpectomy. I think that like everything, it ought to be discussed with the patient as an option and then followed by, I would recommend this for you because of X, Y, and Z. So if you're in an area where that's not reasonable because the expertise doesn't exist in that area, then the reality of it is the patient is going to either have to travel or have it done the way that you're comfortable with. I mean, clearly open surgery is a good, viable way to do things. I think it is beneficial to the patient population to know, though, what the treatment options are, and that's certainly a reasonable treatment option that should be put forward in front of a patient. I would be strongly against having it mandated because I think this is something we as a physician group should be handling and not have it coming from an external body politically to discuss it for us. Maybe just to segue, because this was really kind of focused on technical approaches to things, we have some very experienced surgeons up here. What are the patients? Is SILS acceptable and reasonable for every patient that you would do laparoscopy on? I'm not saying open versus laparoscopic, and if not, which of the patients end up getting SILS in your hands and which end up getting laparoscopy? Are you just cherry picking the best patients for SILS? Brad?
Yeah,
Tonya just shook her head, yep.
Yeah, so my inclusion criteria is that either the fellow is far past their learning curve for straight lap, because it had some implications for training, and I don't think we've seen a significant benefit in some of our data. So, you know, I want to be sure that if the fellows are participating in the case, that they're very comfortable with straight lap first, because my job is to teach them and the residents how to do straight lap well, kind of walk before we can run. If they're at that position and they're part of the case and the patient's body habit is favorable and the BMI less than 30 or maybe less than 35 for a woman and it's not a reoperative case, then I consider it in those patients.
Tonya?
Kind of similar. A patient that I would think would be an easy laparoscopic case is now a Sills case, and the ones that would be, I think, are going to be a difficult laparoscopic case, stay a laparoscopic case.
Currently, I don't do rectal pexy single port. I'll offer them traditional laparoscopy. And some redo Crohn's disease scare me off to do traditional laparoscopy versus Sills.
For me, the main thing that I want to do single port is going to be rectal cancers. I just don't feel like we have the technology right now in order to get the adequate stapling off of the rectum, and there's a lot of manipulation that you have to do with the rectum and the tumor in order to get the stapler across. So those are really the cases that I limit, that I don't offer single port for. In terms of obesity, I actually have done quite a few cases with patients that have a BMI of over 40, and I think it's a little more challenging. The incision tends to be a little larger, but that's mainly because of the thickness of the mesentery and not necessarily the procedure itself. Those patients also do extremely well and can be performed effectively. We have done a few rectopexy with the single port. It is challenging. I think for the most part, I probably would offer multi-port for those cases.
How about, just going down the line here, are you using different instrumentation? I mean, we've heard about the difference in terms of flexible scope versus straight scope, but aside from that, are you using maybe you could comment on that and then comment on, are you using different instrumentation, energy sources, approaches, single port than you are using laparoscopic, or have you just kind of stayed with what you've had and morphed it?
For the most part, using the same instruments. When I started, I was using the angled scissors readily, and I'll still use them on occasion. Sometimes the disease doesn't permit the appropriate angulation, so I have the angled shears available. The majority of the time, it's the same instruments, though.
I started by using articulated instruments, but as I mentioned earlier, I found that where the tip of the instrument is not where by proprioception you expect it to be, my brain just can't cope with a flexible instrument, so I stick with the straight ones.
I use a 5mm straight grasper on all. That's about it.
One thing, at least in my practice, what I've found is that doing single port has actually improved efficiency of instrument transfer, and I've actually cut down on the amount of stuff that I've used in the operating room. So I will really just use straight laparoscopic graspers, and then I use a ligature. Others, I think, have reported using harmonic scalpel. I actually stopped using staplers to take my vessels and primarily use ligature unless there's concern for calcification. But again, I think that this technique has made things a little more simpler for me and a little more efficient in terms of equipment used.
Great. Well, hey, let's give a hand. Thank you very much.